Hello and welcome to the Retina Radar podcast. I'm Arshad Khanani, Managing Partner and Director of Clinical Research and Director of Fellowship at Sierra Eye Associates and Clinical Professor of Surgery at the University of Nevada, Reno School of Medicine in Reno, Nevada. In each episode, I'll be sharing information on the latest breakthroughs, clinical insights, and practical pearls for your everyday use. We'll hear from leading experts, explore cutting-edge research, and discuss the trends shaping our field. Whether you're in clinic, in surgery, or on the move, Retina Radar keeps you informed, inspired, and ahead of the curve. To earn CME credit, visit mededtalks.com, search Retina Radar, or click the link in the notes to complete the activity and post-test. Before we begin, please review the faculty disclosures and learning objectives. If you have a question for our experts, send it to us at cme@vindicocme.com, and it may be featured in a future episode. This podcast is supported by an educational grant from 4D Molecular Therapeutics, AbbVie, Adverum Biotechnologies, Alkeus Pharmaceuticals, Astellas, EyePoint Pharmaceuticals, Genentech, a member of the Roche Group, Neurotech Pharmaceuticals, Ocular Therapeutix, Oculis, Regeneron Pharmaceuticals, and REGENXBIO. Today I'm joined by my friend and colleague, Dr. Frank Holz, Professor and Chairman of Department of Ophthalmology at University of Bonn in Germany. Welcome, Frank.
Well, thank you, Arshad, first of all, for having me here for this program. It's a great pleasure to join.
Frank, we're excited to have you today because this is kind of like the wrap-up episode for our 18-part Retina Radar series. And there has been a lot of development that have happened this year in 2025. So I'm excited to have you here so we can discuss about the recent developments. Many of them you are actually involved closely with. But before we get started, everybody knows you well around the world, Frank. You're kind of global leader in geographic atrophy and imaging and many other things. But many of us don't know how you ended up in retina. So it'd be great for our audience to learn about how did you choose to become a retina specialist and what motivated you to do what you are doing now?
So how did I get into retina? I think there were two factors that fascinated me of moving in the back of the eye, so to speak. It was I grew up and went to medical school in Heidelberg, and this is where this company at this time consisted of three physicians, basically, physicists, must correct, that started an imaging company that some of you may be using their devices with regard and so forth. But it was fascinating to see these first high-resolution images started with confocal scanning laser ophthalmoscopy and then moving forward to OCT devices. So I thought that was really great to in vivo examine this tissue in such a meticulous way and in a fine granular way. So I found this fascinating. And then I actually had a 2-year fellowship in London at Moorfields Eye Hospital with Professor Alan C. Bird, and this made me obviously even more enthusiastic about going into retina.
Wow, that's a great story. So you trained in Heidelberg, where obviously we have all this explosion of images, and OCT really has changed how we treat diseases. I remember when I was in training, OCT was just coming out, and that era, I don't think the young doctors remember, but it was very challenging sometimes to just look at the retina and examine it without imaging and figuring out what's going on. So that's I didn't know about that. So that's pretty cool, Frank, that you actually were very close to Heidelberg. Okay. And then outside your busy schedule, I know you're speaking around the world, you're teaching, you're chairing a department. What is your favorite hobby?
Well, my favorite hobby is actually road biking that I do at least on the weekends with friends. That's fun. But apart from that, just a bit of running, but nothing big.
Okay, great. So outdoor stuff. Okay, sounds good. Okay, so let's get to the topic at hand, all the developments in 2025. Recently, we saw a paper in New England Journal of Medicine that you were first author on, and there's a lot of buzz in the media about this Prima implant. So can you give us a little bit of overview of the Prima implant and findings from the clinical trial that you led?
Yeah, sure, Arshad. So the Prima implant is basically a 2 by 2 millimeter photovoltaic chip, 30 microns thick. And the idea was, and this goes really back to Dan and Palanca, physicists at Stanford, producing this chip with the idea to have bionic vision in the sense that we replace lost photoreceptors, just translating light into electrostimuli. And the starting point here was to have a photovoltaic chip without a wiring going outside the eye. I think we do recall the Argus implants, pretty bulky stuff in or under the retina. There were other approaches, but they usually had a cable exiting the eye for giving energy to these bionic implants and also giving information to them. So that was associated with some complications. The profile was, in terms of safety issue, somewhat a bit challenging. And so this implant, what is really cool, it has no wire. Again, electric energy is given by a photovoltaic mechanism, and patients need to wear a special camera which captures the image from outside and then transfer it onto the chip. And this translates in a retina where no more living photoreceptors are into electrostimuli. And again, the prerequisite here is intact biocomputer of the retina beyond the photoreceptors. And this is the case in late-stage AMD, in geographic atrophy, and patients from this Primavera trial across 70 clinical sites here in Europe who did this kind of surgery was then looked at geographic atrophy where the fovea is completely lost functionally, so subfoveal GA, and then via a temporal retinotomy and forming a flap over the atrophic area. The chip with a special shooter instrument was placed under the retina with a gas tamponade. Temporarily, the retina was attached and lasered at the retinotomy site. And then it took an intensive rehabilitation program, basically, where patients learned how to use it in their daily life. But as a matter of fact, and this was also indicated by feasibility studies, which much lower numbers of patients. This trial had 38 patients recruited with foveal geographic atrophy. And when they learned to use the system, there was restoration of function in the very center that was completely dead visually before the implant was inserted. And they could read words and letters and words and sentences. Obviously, with limitations, it's a black and white thing, no color perception whatsoever. And also it's a bit tedious. It's not fluent normal reading, but I think it really opens the door for a new, exciting era where we can actually restore vision in patients who have lost their foveal sight.
Wow, that sounds very, very exciting. And so what are the next steps here, Frank, in terms of moving the program forward? Is it going to go into global studies? Is it going to get approved? Because a lot of our patients are already asking about it in the
Yeah, obviously the CE mark is now sought in the European Union, and approval is sought by the regulators here in Europe. And as next step, of course, in the US too. And again, I mentioned it's an important starting point. This will be brought and should be brought to market, I feel, but there are lots of ways for him, lots of possibilities and opportunities to improve things. One of it, I'd mentioned, it's 2 by 2 millimeter. And for fluent reading, you would have preferred a larger visual field, if you will. So larger implants, say by 5 millimeters, have already been implanted in animal models, and that would be one of the improvements to come.
Got it. And then how is this implant powered, Frank? You said there's no wires coming through. So is it like a battery inside? Is it going to be like 5 years, 10 years, or permanent?
No battery, like a pacemaker, no replacement necessary. Again, it's a photovoltaic principle. So light is transformed into electric current.
Oh, got it. Okay. Very exciting. Thank you, Frank. That's very exciting times for patients who have lost function. And, we all have those patients with large GA lesions and we don't have anything to offer. Obviously, let's stay on the GA topic. You are a world-renowned expert in GA. You were closely involved with the development of pegcetacoplan and avacincaptad pegol. What are your thoughts on current approved drugs? I know that they're not approved in Europe, but in the US we have their approval, and the market utilization has not been as much as we expected. I use them because I was part of the trials, and I believe that slowing down GA is better than doing nothing. Of course, we have to pick the right patients. But tell us what are your thoughts on the currently approved drugs, and what is exciting coming in the future in terms of retinal pharmacotherapy for GA?
Yeah, thank you, Arshad. Again, as you mentioned, these two drugs, complement inhibitors, C3, C5 inhibitors, are not approved in Europe. So EMA felt, the European agency responsible for approvals, felt there's not sufficient evidence that there's any functional benefit for patients. It's not asking for improvements. That's impossible. As you said, it's just slowing expansion growth of geographic atrophy. So you wouldn't expect improvement at all. And again, the post hoc analysis, the position of the EMA was, you have to show this prospectively in a new trial, and therefore they didn't approve. We are using it here, as a matter of fact, in some patients off label with reimbursement of some insurers. And as you mentioned, patient selection, in my view, is absolutely key. You have to go for the better seeing eye. It isn't meaningful to inject into eye every month or every 2 months for the rest of these patients' lives. So obviously there are limitations, but I would feel that if we consider it in patients with extrafoveal geographic atrophy, usually multifocality, which is a high risk biomarker for high risk for progression, and then the second eye should be down completely, as I mentioned, foveal geographic atrophy. These were patients where we would consider it. But as you mentioned, it's a modern advantage for patients because it's just slowing progression, but not improving anything. But I do feel it is an important step forward. It's the first breakthrough for a signal, a therapeutic signal in phase 3 trials, as we have had failures over the years, lampalizumab and other drugs. So I think it's an important step forward.
What about things coming in the future? We have ANX007 being studied in Archer 2 study. Their primary endpoint is protection of 15 letters of vision loss, which is a functional outcome. And I think this will be welcomed by the European regulators. And then we're also pending data from a new, mechanism of action with ABD104. What are your thoughts on those two programs?
I think these are important next steps and great programs. And ANX007, as you alluded to, is a C1q inhibitor. So it also tackles the complement system, basically puts a brake on as we feel we have to dampen inflammatory processes to slow down the disease progress. And importantly, the earlier studies showed that there's improvement in some patients in vision. And as you rightly mentioned, the cutoff with a 15-letter loss was significantly better in the treated patients. So again, EMA would like this concept as a primary readout, a functional readout. So I would be optimistic, but let's see, of course, what the phase 3 data will be showing. And you also mentioned ABD104, a nanoparticle modulator of macrophages and glial cells, also a way to dampen inflammatory activity in the retina, and also a very exciting new way forward.
Yeah, I think it's nice to see, as you said, that we have 2 approved drugs with modest benefit of treatment, but is better than doing nothing. And then now we're looking in this next wave of, drugs. Obviously, it's a very high bar. You and I were both involved with lampalizumab program, and it's a high bar to achieve success in clinical trials. But yeah, very exciting that we have ABD104 phase 2/3 data coming out soon, and then ANX007 Archer 2 data likely end of next year. And Frank, there's a lot of developments in oral and systemic treatments for geographic atrophy, as well as stem cells for late stage patients like you mentioned who are receiving Prima implant. Where do you think the field will go in terms of systemic treatments? You think there's a chance that we'll be able to have a systemic treatment for a disease like geographic atrophy? And then where do stem cells kind of fit in your treatment paradigm?
So the systemic application would be a huge advantage. We could really treat both eyes bilaterally at the same time without sticking a needle into the eye every month or every second month. So I would be very in favor of such a route of administration, but this is early days. There are several programs out there, but they have to give evidence of efficacy and safety.
Yeah, no, I agree with you. I think, patients will love it. Physicians will like it because of the treatment burden in our own clinics. But again, a difficult disease and not easy to get there. But I'm excited to see many pills, many systemic injections that are being studied. And lastly, what are your thoughts on the stem cells? We have seen some positive data from the stem cells trial in terms of restoring some function. I think likely reserved for advanced stage patients, but what are your thoughts on it?
Well, stem cells seem like a really high bar in early days, didn't show much. They were clumping of pigmented cells. These were RPE cells transplanted. But now I have seen one program, and as you say, restoring not only vision, but also OCT bands, outer retinal layers after the application of these cells. So this is amazing. And so I think it does hold mileage, and maybe also on top the gene therapy programs that are now out there would also be an important avenue to go just once and done treatment, no repetitive injections in the eye. So this would also hold promise in my view.
Yeah, no, I agree. I think gene therapy and stem cells clearly hold very big potential, but early days, as you said, and we'll see how the field turns, but very, very exciting. I think restoring function, as you mentioned, is important for our patients with GA, especially advanced. So they're targeting that, especially with stem cells. So we'll see. And of course, gene therapy fitting in with decreased treatment burden and hopefully stopping or slowing down the progression of GA would be very beneficial for patients. Okay, let's move on to wet AMD for next few minutes. You've been involved with all the developments that have happened in the past with wet AMD. Now we are at another stage with tyrosine kinase inhibitor. We have OTX-TKI as well as EYP-1901 finishing their phase 3 clinical trials, and we are expecting data over the next year or two. These are injection implants that decrease treatment burden. And then, of course, we have gene therapy, we have intravitreal gene therapy, we have subretinal gene therapy and subretinal gene therapy with ABBV-RG314. They finished the phase 3 recruitment and we'll have data end of next year. So where do you think the field is going over the next year or two in terms of treatment for wet AMD with TKIs and gene therapy?
Yeah, Arshad. So first of all, I mean, the dynamics in this field is fantastic and enormous. So many new things being tried out, new targets found out, the tyrosine kinase inhibitors, obviously, as you mentioned, with the devices injected into the eye with a slow release, and they maintain efficacy over a longer period of time, would lessen the burden for patients and healthcare providers, obviously. So I think this is really exciting. We need to await the results of the phase 3 trials, obviously. But again, that would be a huge advantage. Then you mentioned gene therapy in this space. And I personally was really amazed to see the enormous reduction of supplemental injections in these high flyers with many injections before and high frequency injections in these eyes. And then with the gene therapy, it went down over 90%. The first 1 or 2 years, didn't need any supplemental injection. So again, this would be a huge benefit for these patients, not those who require the off and on injection every 3 months, every 6 months, but these really high flies with monthly, 2 monthly injection.
No, I agree with you. I think there is, some questioning of gene therapy from the community, especially, the investor community in the U.S., Frank, where feels like if you're going to do gene therapy, you need to cure 100% of the patients, but 90% reduction in supplemental injection burden, 50 to 70% of patients injection free. I think that's very meaningful for patients as well as clinicians. What are your thoughts from outside the U.S. In terms of like the potential of gene therapy, that we are not going to cure everybody because there's a drug delivery platform. This is not a gene replacement platform, but as you said, the data has been very exciting. We recently saw the PRISM long-term data with 4150 intravitreal gene therapy, which really shows that we are continuing to see efficacy, just like we saw with XOAC and also in the long-term data with ABVRGX314. So do we need to cure everybody, or significantly reducing treatment burden, curing half of the patient is meaningful?
No, it's amazingly meaningful. I completely agree. I think the European perspective is quite positive towards any gene therapy. We have done at our site BN1/30 Luxturna injection with subretinal injection in biallelic RB65 mutations. So it's doable. It's not a big surgical thing. Again, we know from other programs that there's also intravitreal injections would again also be an advantage, obviously. But I think we have the capacity, even in a common disease, to perform this type of surgery in the future. And again, the data look really very promising. Again, in the end, it's patient selection. For some patients, it will do the job. For others, we select other treatments. But if we have a whole armamentarium we could choose from, that's obviously, for us physicians, the ideal way forward.
No, I completely agree with you. It's nice to see the excitement outside the U.S. for gene therapy. As you know, I'm a big fan of it, and I've given many talks, as you read in your session year after year
exactly.
and it's been nice to see the data build up over time. And I think we are at that critical juncture now where we are going to see a lot of phase 3 data in the next year or two. I think this is going to really guide the field. So I think it's very exciting to see that. Okay, last topic before we wrap the podcast up. I know, ocular melanomas are not very common that we see, but they're kind of, not discussed much, but we have seen, advances in the melanoma therapy. Do you see, melanomas in your clinic? Do you see nevuses and early melanomas? And are you guys doing plaque therapy or systemic staging? And I know there is an exciting program going on, AU011, with an investigational product for the treatment of melanoma. So just give us a quick overview about melanomas and if you are evaluating and treating them.
Yeah, we actually do have an oncology service taking care of patients with nevi choroidal melanoma. And I think it's really important to make the distinction. Is it just a benign brown spot, or is it moving towards a longer benign lesion? But I think all the work comes really from Shields and Shields, obviously, teaching us how we can distinguish a benign lesion from one more advanced and potentially no longer benign lesion. And I think the factors that we also applying, again, having all learned from Shields and Shields, is thickness is important. Everything above 2 millimeters is suspicious. Subretinal fluid lends to a more less benign lesion. Symptoms are always of concern. And as we know, orange pigment and absence of drusen are signs that would point towards a lesion that we need to be concerned about and may go into a choroidal melanoma. So we have really good morphologic markers to tell us. And again, from the work from the US, from Shields and Shields, it's that we use these criteria on a daily basis, as a matter of fact. So as you mentioned, we also treat melanomas, here choroidal melanomas in our oncology service, usually with ruthenium plaques, but this is a relatively invasive approach and procedure. And having an injection in the suprachoroidal space, as it has been done with AU011, holds promise to control these choroidal melanomas, and again would be a great success story forward in a better treatment for these patients. So we do radio plaque therapy here, but having something to be injected in the eye, much less invasive, would be obviously fantastic. And I would much hope that this will yield positive phase 3 results.
Yeah, no, I know I don't treat melanomas, but I do have many patients with it and I refer them out. So I think that's a field we haven't seen too much innovation. So I think it's exciting to see what AU011 can offer to our patients. Okay, so Frank, great discussion. Really enjoyed your take on all the developments in 2025. Tell me, what are you excited about in 2026? Anything you're really looking forward to? Of course, we discuss all the data set that are coming out, but tell like your top 2 or 3 things you're really looking forward to.
Yeah, I would say all of the above that we
Okay, that's
discussed today. But I would be particularly excited about the gene therapy programs we were talking of. And there are other devices with longer durability in a chronic progressive disease. We just need other solutions than repetitive high-frequency injections into the eye. And again, many extremely promising programs.
All right. Thank you, Frank, for being here. Really appreciate your insight, and thank you for leading the field to bring better treatments for our patients, and your work on Prima implants and everything else you're doing for our field. So it was an honor to have you on this podcast, Frank. I appreciate it. I want to thank you for excellent discussion, and of course, thank our audience for listening in. Thank you, Frank.
Thank you very much, Arshad. Great pleasure to join.
To earn CME credit, visit mededtalks.com, search Retina Radar, or click the link in the notes to complete the activity and post-test. Have a question for our experts? Send it to us at cme@vindicocme.com, and it may be featured in a future episode. Stay tuned for future episodes in the Retina Radar series to keep up with the latest insights and expert discussions.